Good afternoon. I'm presenting this abstract on behalf of the Hepatitis Group, MRC, the Gambia, at the London School of Hygiene and Tropical Medicine. I am retired Major, Dr. Ousman Bah. As you can see, the abstract is called The Effectiveness of the EASL Hepatitis B Treatment Criteria on Clinical Outcomes in Africa. This is a post-hoc analysis of the famous PROLIFICA cohort study in the Gambia. These were our aims and the background of the study. I think, like previous speakers have said, we don't have a lot of data from Africa that inform decisions in making some of these treatment guidelines. So we need more studies from Africa to actually inform WHO on some of these treatment guidelines. So, but what we have now is the EASL criteria and other guidelines that we use. So we have to put them into our African context. So this study will show us how effective is that in implementing such guidelines that are developed from a non-African setup. So the methods we followed up the PROLIFICA cohort that was established in 2011 in the Gambia. We used the 2012 EASL guidelines, and participants were assessed and started on TDF based on those recommendations. And the primary outcome was the overall mortality, and also the secondary outcomes were mostly liver-related events in the untreated and treated groups, and the long-term safety of TDF. So these were the results. As we can see, from December 2011 to October 2015, 1,413 participants, treatment-naive chronic Hep B patients, participants were recruited, of which most of them were in the population-based cohort, and also few were from the hospital-based cohort. And 960 participants without HCC or HIV or hepatitis C co-infections were assessed, and 112 were found to be eligible and initiated on TDF based on the EASL guidelines. And majority of the cohort, that is 88.3%, were ineligible, but were still followed up to be monitored for progression of liver disease. They were mostly male and had a baseline age of 36 with an IQR of 31 to 45 years. So the results show that there were 55 deaths over the median follow-up of 7.2 years, and 29 deaths from the treated group, which were mostly, as we can see from which were mostly due to end-stage liver disease and also cirrhosis. HCC rather. So 26 deaths were from the untreated group, and mortality rate we can see was 7.5 deaths per 1,000 person years, and survival was lower in hospital-based patients. Survival was lower in hospital-based patients because they were the symptomatic group. And we can see, like I said, most of the deaths were end-stage liver disease and hepatitis, hepatocellular carcinoma, which further shows how we must improve in providing care to that particular group. And the age standardized mortality rate in the asymptomatic group was lower than the general Gambian population, and which shows that healthy, ineligible chronic hepatitis B patients are likely to survive, have higher survival rate than those in the general population. So liver disease progression, we saw that those that were untreated were followed up, and during this period, about 36 became newly eligible for treatment, and 5 had fibrosis progression. But however, the the biggest risk factor we saw was hypertension, which had was significantly linked to progression in this group. So from the treated group, 74% survived. However, among the cirrhotic group, 54 showed regression. And treated patients had a high incidence of HCC as expected than non-African studies. So we also detected 87% had undetectable viral loads, comparing to the initial, when we started them on treatment, they had detectable viral loads, but during the follow-up, we could see that there was successful suppression of the hepatitis B virus. So their adherence was very good. And also, in this cohort, we could see that there was 1.9% among the ones that were treated that developed kidney impairment. So there was no significant difference between the treated and the untreated group. And most of the patients were having normal creatinine values, and also the estimated GFR was normal, as we can see from the table up top. And most of them were at stage 1. That means significantly the renal profile was good. And about 76 patients had DEXA scans, 46 of the treated group, and 30 from the untreated group. So which showed that there was no significant difference in bone mass density and between these groups. So TDF exposure did not affect bone health significantly, as we can see from these results. But then we used the 2024 WHO guidelines to assess this group, and we found that 48% of those that progressed would have been treated with these new guidelines from WHO. But that's among the treated also, we saw that 30% who didn't progress would have been treated. However, we know as these guidelines are produced, more people will be, more groups will be included, and likely many more people will be treated if we are comparing them to the previous to this cohort that was monitored. So in conclusion, the EASL treatment criteria had excellent long-term clinical effectiveness, except in cirrhotic patients, reflecting late diagnosis and suboptimal management of cirrhosis in Africa. The updated EASL criteria should further help in identifying patients at risk of disease progression, and early diagnosis and comprehensive management of cirrhosis will help in the survival of those that are diagnosed already. I think from the context, this is information that almost everybody knows, but what is important is how we know the groups that are supposed to be treated. We know what we are supposed to do, but how do we take this treatment to those that really need it and at the places they need? That's the most important step that we should take next. So I thank everyone. This was the team, and these were our sponsors and partners. Thank you.